Okay, we're going to move forward with our last session for the day, and I think we should be able to end a little earlier. I would like to ask for your help with two things. One, when you came in the morning, you would have been given a feedback form. Would appreciate if you could complete that and leave that at the front desk before you leave. Our registration desk is just by the elevator. Second thing, for those who are actually looking for, want to claim CME credits as well, the claim forms are also at the registration desk, so please feel free to fill them out and you can return them to us and we will take care of the processing for you. So our final session for the day is around successful hepatitis campaigns, really from how the concept was developed to how it's actually being implemented. And so we're looking at both hepatitis B and C. Our first presenter is actually Janet Zola, from the San Francisco Hepatitis B, Hep B Free campaign, which has been a really successful campaign with multiple stakeholders in San Francisco who have come together, legislators, public health departments, community-based organizations, and we're hoping that Janet will be able to share with us some of the lessons learned from that model to see how it might be replicated in Midwest cities like Chicago. Janet.
Yes, in 15 minutes, I'm going to answer all your questions, tell you how to save the world, and condense 5 years' worth of work. Can you see me over this podium? No, it's kind of nice to be behind the podium for a change. Okay, so I'm especially pleased to be here because I'm actually a Midwestern girl myself. I grew up in Madison and Milwaukee, so it's wonderful to be back here in the Midwest talking to all of you. Oh, hold on a second. I brought the agenda up. So when I talk about our program in San Francisco, I like to give people a quick overview of who we are in San Francisco because we're on the forefront in so many areas. I think people forget what the reality is of our city beyond the fact that we're pretty progressive, including our health department. So you can see that we are not anywhere near the size of Chicago. However, we do have the densest API population on the mainland. Only Hawaii has a denser population than we do. The Bay Area is also very dense, but in San Francisco itself, over a third of our population is of API descent, and in the entire population, 20% is Chinese. So you can imagine that hepatitis B is really an issue for us in San Francisco. So back in 2006 is when we started looking at this in the API population, and we had the good fortune to have 3 groups come together as the basic core planning group, the founders. So we had the Asian Liver Center at Stanford University, the San Francisco Department of Public Health, Communicable Disease Control and Prevention, and the Asian Week Foundation. And then we also had the good fortune of having one of our own politicians, Fiona Ma, who is currently the Speaker Pro Tem in the California Assembly, be sort of our poster child and our honorary chairperson. And Fiona herself is infected with Hep B. She is not on medication, but in the process of working with us, she learned a great deal herself about her infection because she started out with the idea, like so many people, that she was a healthy carrier and didn't have to see a doctor and didn't have to worry about it. And that level of information changed. So we started doing our planning for this program back in 2006 and launched it in 2007. So in terms of trying to do this broad brush presentation for you, I just want to point out the fact that there were many months of actual strategic planning going on and times when, as the word was getting out that we were going to do this large-scale campaign, that people came to us and said, we want to work with you. And we literally said, please wait, please wait. We've got to get the medical piece in place first. We're going to work with everybody, but in this initial stage, we want to keep it small. Let us get all our ducks in a row. And in the beginning, we created these 3 campaign goals to create public and healthcare provider awareness on the importance of testing, vaccinating, and referring to care, promote routine hepatitis B, which is what we've been hearing about all day, and ensure access to care. And happily, those three goals have withstood the test of time. They are still our primary goals. And I think they also would translate very nicely to hepatitis C. I think we're looking, that's one of the crossover places that we're looking at the very same issues in terms of hepatitis C. So we picked 4 main strategies to make this awareness happen. So a lot has happened in the country in the last 5 years. Much of it mentioned today, that IOM report, the recommendations on screening that came out. None of that was in place, and we would walk around and talk to people. And I don't think you in Chicago and in the Midwest are 5 years behind us, but I'm sure, somewhat behind us, because the level of awareness we've been able to create in San Francisco, we hear from outsiders who come in that it's noticeable, that our clinicians all know who's supposed to be screened for hepatitis B. That doesn't mean they're doing it, but they know who's supposed to be. 5 years ago, both our general population, our at-risk population, and our providers also were all over the map when you talk to them about chronic hepatitis B. You know, who's at risk for chronic hepatitis B? Let's see, men who have sex with men, IV drug users. You know, they were looking at acute concerns, and I suspect all of you are aware that our incidence of acute hepatitis B is dropped enormously dramatically because of our universal Hep B immunization program in this country. So really the reservoir now for hepatitis B infection is the chronic infection. So we also saw this as an issue for the whole society, as been mentioned also. It isn't just for Asian and Pacific Islanders. And we also were well aware that we needed to be able to link people to care once they were identified. So this comes up in discussions over and over, doesn't it? How in the heck are you going to get people into care? You've gone out and you've found infected people, but then what do you do? So we were looking at all of these to make sure we had the pieces in place. If you're going to raise awareness and say to people, you know, you're at risk of having a life-threatening chronic disease that you should know about so you can protect yourself, you have to have some place for them to go to get tested. You can't just say, hey, you should get tested, and they're walking around in circles, or you should get vaccinated. Also hard, you know, to do. And then once we do identify them, then what? You know, and this addressing this question varies pretty dramatically from place to place. So we started out by talking to our medical community to get them on board with us to create these windows of where people could go to get tested. And I'll talk about that some more in a second. Just a quick look at what we've accomplished in terms of screening, and we actually don't like answering the question, which is always the first question people present to us, how many people have been screened. We don't really like answering that question because we don't feel like our program is actually about us screening people. It's about us educating everybody about the need to be screened. Our primary message is go get screened at your doctor. We want that continuity of care. We want this to be sustainable and to be rolled into the medical infrastructure. We don't want to be creating new sites, new places, new systems for people to do this. But everybody always wants to know how many people have you screened, because, you know, something you can count, you know, they tell us a lot is not a number. So we did look at this, and we have, like everybody, there isn't any way to know how many people in a community are screened because we don't have a registry for everyone who's been screened. A lot of communities keep track of positive tests in the health department, so we do too. But that doesn't tell us who's been screened because we don't have, we're not entitled to see negative results. So at the end of, as of December of 2010, which is the last time we did analysis of this, we had screened well over 7,000 people at the specific Hep B-free events and screening sites only that we had set up. And the piece of this that interests me the most, because I am a health educator by training, is the 72% of positives who did not know that they were infected. Now, in the one hand, that's good. We don't want people who know they're infected coming to our free screening sites because we want to save those resources for people who can't. But they do come because they got tested and then they got vaccinated and they go, oh, it's free, I'm going to see if the vaccine worked. Or they've been tested and it wasn't fully explained to them, so they go, maybe it went away, I'll get tested again. But our data in terms of them being unaware really speaks to everything this conference is about and everything we see everywhere else, this large percentage of infected people walking around with a time bomb and unaware of the risk that they're facing. So once we felt like we were ready to roll, we did our official launch in the Asian tradition over a meal in Chinatown. Had a big press release, got a lot of coverage, and if you look at the picture in the lower right-hand corner, I like to include that because all the way through we had a lot of fun doing this, and I think it was, I do think having fun when you do the work, even though it's very serious work, it does keep people engaged and happy to work with you. You can see by the size of the room, we had about 500 people there. There were about 150 different community groups represented, both within and without the healthcare field. And when you see our list, you'll see the diversity of partners that we brought in. We did have a few keys that we considered keys to success. So we did both top down and bottom up. We did go to the CEOs of the hospitals and the policymakers and recognize that if a CEO is convinced that this is important, it makes it very easy for the people underneath who are actually going to do the work to do it. It's much harder when you go to the healthcare worker or to the nurse practitioner or somebody that's lower in the level who gets completely sold on this, and then they have to go and sell their top management on doing this. If we went straight to their top management, and that was a part of how we actually got hospital groups to set up these free clinic sites, because the CEOs of the hospital said, this is great, we'll do this. And then they gave us the name of who we should talk to at the hospital. And the person at the hospital would go, no, it's not me. No, you mean, and after 3 rounds, you finally got somebody who couldn't pass the buck anymore, and then they would go, well, how do I do this? What'll it cost? How many people have to be screened? And basically what we said to them is, look, we need you to do this. We're asking you to provide services to people who actually are not your patients, which is not what our medical system does. And we're asking you to pay for it because we don't have any money. And we can't tell you how many people need to be screened. We can't tell you how many people need to be vaccinated. And we just want you to create a window. You don't have to do it 5 days a week. Your CEO said you were going to do it. So you and your staff can put together whatever you think your capacity is, and then you shoot it back upstairs, and they have to find the money for you. And amazingly, it worked. It meant we had 7, no, we have up to 8 now, freestanding Hep B free screening sites that provide free screening, free or low-cost vaccination, and referral to care. The other, and of course we started with the community, and this has been mentioned over and over, and I can't agree more, that the community is absolutely, absolutely critical. And it's really helpful in San Francisco because the community represents so many votes. And we do have quite a few elected officials who are of Asian descent, but even if we didn't, because we have such a large population. And in Chicago, you've already got some policymakers and some, our first speaker this morning on your side. And it makes a big difference. They may not give you money. Same thing with health departments. It makes a big difference when you engage your health department. I guarantee you, your local health department isn't going to give you money, and maybe not even as much time as they allowed me to do on this. But the health department brings with it this clout, this credibility, and the other thing is that the health department knows what's going on in the community. They know which clinics are providing which services. They collect data. They know how to give you all of that stuff that helps you build your case to get funding to engage other people. We looked for very diverse partners. We didn't stick to what we considered to be the norm. So interestingly enough, a good percentage of our participating active partners, people who are really doing something, are from outside the healthcare field. I think those of us in public health in the healthcare field tend to think that if we get lots of different community-based organizations, health clinics, and the health department, and a few private medical practices, that we've done a good job of diversifying. And I would just suggest to you that we haven't. That until we bring in the businesses and the sports teams and the Miss America pageants and the American Legion offices and all of these other places that bring not only more resources to you, but different perspectives that allow things to get done that we in the health field don't think about. We had one person who had a connection to a printer, and so one spring we printed, I think, 100,000 biodegradable plastic bags, because in San Francisco, plastic bags are outlawed, that had our logo on it and had our message on it, and it was trilingual, and we handed these out by the thousands to merchants who put groceries and whatever they were doing in it, and it's not something we necessarily think to do. And certainly your healthcare obviously is very important. So can you read any of those? Is that legible? If I were out there, I wouldn't be able to read it. But there's the usual suspects in there, and a couple of interesting, not usual suspects that are in there is Sterling Bank and Trust, Subaru of America, the Golden State Warriors, which is the Oakland basketball team, and the Giants, who we just did our annual event with on the 1st of May, a couple of churches, Beach Blanket Babylon. How many of you have seen Beach Blanket Babylon? Yeah, my one, San Francisco. So when you plan your trip to San Francisco, this is an institution. It's a cabaret sort of a thing that does political spoofing, and they're known for these enormous hats that they wear. And they take the political stuff and they make spoofs and songs about it. And they became a partner with us. We've certainly worked with our local politicians, and I think I'm not going to try to tell you who they all are, but I think you recognize the lady in front, and this was her first public speaking after the Healthcare Reform Act got passed. It was 2 days later, and this was in Chinatown, and she was talking about healthcare reform, but she did also talk about hepatitis at that time, and she's certainly been a champion for us, as are all those other politicians that are up there. Activating the community, that means educating them, reaching out to them in ways that they can relate. You can see a photo here of it's Asian media that we're talking to. That's our Subaru Hepmobile. Subaru gave us a branded car that we drive around with our logo, so we take it to all of our events. And have a lot of young people. Now, I'm going to refer back to a comment Dr. Kim made earlier about scare tactics. And the next slide, I think, is what she's referring to. So what we did, this is not the scare tactics. So we did media campaigns as part of our public awareness. And what we did is we did them in language in the ethnic newspapers, but in English in the outdoor advertising and the PSA, the billboards in this, because we have so many Asian languages spoken in San Francisco. It was sort of like, how could you, if we put just Chinese on it, then is everybody else going to think it's a Chinese issue and not a Laotian and a Japanese and whatnot? So we started first with this bus board with Fiona Ma and our governor at the time, Gavin Newsom, as a way to give it credibility and validity and familiarity. These were faces everybody in the community knew. And then that was in 2007. In 2008, we adopted this Be a Hero concept. Now, what we heard when we did follow-up with this is, yeah, this is very cool and very nice, and we love it. What does it mean? Well, the intent here was, let's address the stigma. Nobody talks about this. People tend to not talk about it anyway. The Asian community really doesn't talk about it. And they had as many misconceptions about this disease. They were more aware of the disease than the rest of the population, but just as misinformed. And so the idea was to destigmatize. Everyone can be a hero. Talk to your family, talk to your friends, talk to your doctor. get tested. This affects all of us. So that was in 2008, and our next big campaign was in 2010. And to this day, we would not recommend doing this in other communities unless you've done the pre-work to prepare the community to handle it. This is a very in-your-face message, and it was a lot of blood, sweat, and tears to get to a place where we were okay with doing this. Interestingly enough, when we showed the mock-ups of this to people in the Asian community, they would tend to say, yeah, tough, but we really need to hear that message. When I would show it to colleagues in the Caucasian community, their reaction was, you can't do that. And in fact, the in-language ads do not use the word die, because that is just a little too powerful. But there's 3 more besides this. There's also young basketball players, office workers, and a family. And the message is obvious. This to us is a take action. Like, we're serious about this. This really is a problem. There really is something you can do about it, and you ought to do it. And the behind-the-scenes piece about this campaign that you don't get to see is that in all of these posters, these people are all volunteers. They're not professional models, and they all come from within the community, including the physicians. So these are practicing primary care physicians at UCSF, at Kaiser, in our safety network, at the VA hospital, people whose patients will see them. And for a lot of people, there was very serious thought given to having their picture up there. We had lots of big billboards up associated with this disease. And it not only worked to get a lot of attention locally, but it brought a lot of attention nationally, I think. And I think a part of why Hep B Free has become more known nationally, because the PBS NewsHour ran a story on this, the New York Times did a story on this. So now we're doing all this awareness. People know I ought to do something, but they have to have some place to do. So now we're back to creating these screening sites. A couple of them are open once a month for 3 hours. That's enough, just some place to go to deal with the cost barrier and the convenience factor, and maybe the fact that people don't have a doctor or don't want to go to their own doctor because they still feel there's too much of a stigma to go there. We still would prefer they go to their own doctor, but we've now provided a place for them to go, not only to get screened, get a blood draw and be screened, but if they end up being susceptible, that they can get vaccination either very low cost or for free. But if they're infected, this is actually one of my favorite pictures. If they're infected, everybody who was doing this agreed nobody would be left hanging. Somehow everybody would get referred to care. So first step is usually referring them back to their primary care provider if they have one. If they don't, the screening site who owns the patient either brings that patient into their own system if they can, or refers them to our safety net of clinics, of which we are fortunate in San Francisco to have a pretty robust system. And I think, I hear people talking about various clinics that can do that, take uninsured people. But if you're going to refer back to a primary care practitioner who doesn't know anything about hepatitis B and what to do with it and what to test and what the tests mean and what to do next, then you haven't really done these patients any good. So simultaneously to all of our outreach in the community, we were doing massive amounts of physician education. Started out that first year with lots of CMEs, bringing in the drug companies to do theirs, doing grand rounds, doing them every which way we could, and brought together a group of physicians to put together this diagnostic flow chart, the one-page, simple to use. There are lots of versions of this sort of thing out there, but it's an easy way to look at a glance and see what it is. And interestingly enough, we only did physician clinician education for 1 year because by the end of that year, all of the hospitals in town had taken it upon themselves to do it and built it into their own system so that we no longer needed to do that. And again, this is all related to sustainability, right, and being in the infrastructure. But what we did do was create what we call a Hep B clinician honor roll. And actually, the Chinese American Medical Society in New York City just launched their version of this about 2 weeks ago. The idea being to get primary care physicians to physically sign a pledge to screen for hepatitis B according to the CDC guidelines. Now, for us, that meant screen API, but there's other people, obviously, that need to be screened. And then we periodically publish this list, and doctors, fortunately, have a tendency to be competitive, and so we just played on that competition, like, why isn't my name on that list, you know? And sometimes we get a little bit of criticism from people, and they go, well, you know. I mean, the first thing we heard when we were so happy there were recommendations was, well, nobody follows recommendations, nobody reads recommendations. And the answer to that is, well, that might be true, but then when a doctor says to me, there are no CDC recommendations, come back and talk to me when there are, I can say, yes, there are. There are CDC recommendations for this. And we know that this does not change practice, which is what our goal. However, it is a first step that can be leveraged, because now we know that these people who have signed this pledge, at least they know these guidelines exist, and they might have even read the summary of them, but they definitely know the guidelines exist. And because it's very hard to get doctors to respond, they've gotten this in their fax machine, in their mailbox several times. You know, it's like, if you want it to stop, sign it. And the best luck we had was when we had a physician champion in an organization. So we have several of our organizations, Chinese Hospital, Kaiser, where we have 100% signature, because basically a champion doctor said, nobody leaves the room, look at this that we've put in front of you, and please sign it and do your best to follow it. This is our logic model, and again, I don't know if you can see it that clearly, but you've got it on your thing. So it just lists all the various components that we felt were important to include in our work, from the political community, mainstream and general society, the API community, the healthcare providers, and the healthcare systems, because the providers need the systems if they're going to really be able to carry this through, the independent physician associations, the large medical systems. And the end goal is, in the short term, well, to have increased screening, and of course in the long term to reduce liver cancer. And I think what we all want to do right now, and fortunately, thanks to Howard Koh and John Ward, we now have a roadmap for what needs to be done in their viral hepatitis action plan. We honored Dr. Koh at our gala and gave him a trophy and a cape. It's got a big B on the back, you know, our Be a Hero B. He got a big kick out of that. But this is what we really want to see happen, and this is a rendering of places around the country that are replicating this model at some level. Some are really pretty far along, and others, like Chicago, are just sort of muttering about it. But you know, when I've had conversations with people that have some interest, we go, all right, let's put them on the map, because maybe something, and you've got something started here that's right along the way anyway. So if you haven't read the Viral Hepatitis Action Plan, I would encourage you really to do that. And it's 94 pages long, but in fact, you don't need to read the whole thing, because it's nicely separated into 4 sections, and you're probably only concerned with 1 or 2. Like most of us in the room, I don't think our health department and from the state's concerned with surveillance, but our CBOs aren't concerned with surveillance. And they have it all sort of laid out. It gets deeper and deeper. So you really just need to look at, okay, year 1 in the first part. And they outline very nicely what needs to be done and some strategies for how to do it. What I would say to you in conclusion is to think as creatively as you can. That's come up over and over. To think outside the box. Give new things a try. Look for champions. Look for champions anywhere you can. So the fellow on the cover of this calendar is Alan Wong. He is a reporter and an anchorman for our local ABC News. He is chronically infected with hepatitis B. He is on treatment. His wife is also infected but not on treatment, and his children, because they got immunized at birth, are fine. They're not infected. So he is a marvelous spokesperson for us, and he actually came out about his infection on his TV show, which is actually, I happened to be watching it and heard him doing it and just about dropped my teeth, you know. And it was like, so celebrities, politicians, local people that folks know. It makes an enormous difference, and it makes an enormous difference when people are able to look at a face that they can relate to. And I just think it's wonderful that you're all getting together like this and that you are doing fabulous work here in the Midwest. I applaud you for that. Thank you.
When you test and find people that are positive and try to link them to care, do you track how many end up in a system and stay in that system?
We don't, and that question is asked a lot, and now we now have a collaboration of our healthcare systems who are trying to figure that one out. This campaign was primarily about awareness, and so what its goal was to do everything we could do to get that patient to the door of care. And we recognized early on that care in this case is a very complicated matter, and so the decision was made that our goal is to get them to care and then to let the medical experts take care of it from there. Some of the places that do the screening, the amount of tracking varies. We don't ask them to do that or report back to us, but some do and some don't, and it's a little bit like leading a horse to water. I mean, you know, when we first started doing this, the people in the health department who did the hepatitis registry were freaked out. And they were like, oh, you can't do this, you're gonna overwhelm us, there's gonna be so many tests, we don't have the resources. That didn't happen. The reality is, and I'm sure you've seen this, overall, people are not really super eager to run out and get tested for what might be a fatal disease. You know, it's like not the top thing on my calendar to do. So it takes a bit of pushing to get people to do it, we found. Other questions?
I had a question. Can you comment more on your provider or healthcare education component? You talked about the honor roll, but getting into either academic centers or was it medical students, residencies, maybe a little more than nuts and bolts of how that worked?
Right. So the pharmaceutical companies, and we primarily worked with three, GlaxoSmithKline, who makes a vaccine, and Bristol-Myers Squibb and Gilead, who have treatments. They wanted to come into the community and do CME dinners. And we helped organize about 15 of those that first year. Those are nice, but doctors, get so much of that, it doesn't really turn them on particularly to go to them. And the other thing is, at least within the health department, in my health department, anybody who would be prescribing medication is not supposed to go to those things. It's seen as a conflict of interest. But we had enough connections with the academic institutions in the city and with the major hospitals, and actually even without them, you can just call them up and say, we'd like to get on your schedule for grand rounds. What do we have to do? In a couple cases, hepatologists that worked with us who had somebody at UCSF who had a standing slot, and because getting into the UCSF grand rounds takes forever. So she gave us her slot to come. And people really showed up for these. And as they started seeing this information coming at them from more and more places, this was the other benefit of when you do the general population instead of just the at-risk population, you are also reaching all those doctors out there in the community, and they're seeing it every way. There's one other thing that we did that I don't talk about as much because it's not as well defined, but we also have a big component of driving patients to ask their doctors. So there are studies that show when a patient asks, they're much more likely to get tested. Something like 9 times more likely to be tested if the patient asks than if the doctor suggests.
So building upon the, it sounds like you gave a grand round session, or did your campaign go in, or is that material that you'd be able to share, the content of the...
Well, here's the interesting thing. So I'm not a
rounds?
clinician, and this I doubt is going to come as a surprise, but doctors like to listen to doctors. So we would make that connection, but then we would go to our experts and we would have them do the grand round. We would tell them what we wanted, because our goal in the beginning was please don't talk a lot to these primary care physicians about treatment. The primary care physicians first need to know a step ahead of that. And once that started, then the primary care physicians wanted more information, because if somebody doesn't need to be on treatment, there's no reason for them to move to a specialist. Once those tests are, if you know what tests to do, they can be managed, right, in primary care. And for a lot of parts of the country, that's pretty critical because there aren't enough specialists to go around. So yeah, you have to bring in your medical experts to partner with you. And let me just say to you, if you haven't already experienced this is a really easy sell. I think, it used to be much easier than Hep C. It might not anymore, because now you can cure Hep C, even though it's sort of difficult. But people who knew nothing about the situation with APIs and hepatitis B, when they heard the disparity involved, that there was a vaccine and that there was an easy medication to manage it, it was like a no-brainer. It's like, well, why don't we have a handle on this already? So that was very encouraging, that people just wanted to take care of this. Let's put the lid on this. Thank you.